Here. Okay. Share my screen. All right. Can everybody see the PowerPoint?
Yes.
Awesome. I think we can turn this up here. Maybe not. Okay, so if you guys have any questions, make sure you put them in the chat and we can go over those at the end. Otherwise, this is Alina. She is a pharmacy resident and she is going to be talking to us about chronic heart failure and some medication management.
Thank you. All right. So yeah, like Meredith said, my name is Alina. I'm one of our PGY1 pharmacy residents, and I have been working alongside Meredith and Andrea in clinic as I'm on a AMP-Care rotation with my mentor and preceptor, Tiffany Gonzalez, who also helped me to prepare this presentation with you guys. Just to start, we don't have any disclosures or conflicts of interest to share with the group today. As Meredith mentioned, we'll be reviewing some of the updates to the guidelines that came out earlier this year. We'll also be discussing some of the new classifications or titles that we'll be classifying heart failure with per the guidelines, and then providing examples of new guideline-directed medical therapy. For your reference, these are a list of the many abbreviations that are used throughout the PowerPoint. So this slide may look a little familiar to you all. I took this straight from the guidelines. This is the classifications or stages of heart failure that's used by AHA and ACC. So specifically in stage A, this is called patients that are at risk for heart failure. These are patients that have not had current or any previous symptoms of heart failure and do not have any structural heart disease. This includes patients with the comorbidities that are listed down in that bottom green box. Stage B is considered pre-heart failure. So these are patients that are still not having any symptoms or don't have any history of heart failure-like symptoms, but they do have one of the three following lighter blue boxes. So either structural heart disease, evidence of increased filling pressures, or one of the risk factors listed below. And then stage C is what we consider our symptomatic heart failure.
Sorry.
It's okay.
Somebody's waiting in the lobby. Let me see if I can. Where did it go? Do you guys know how to let people in the lobby?
I'm not sure.
Here, I'm going to stop presenting for a second. Oh.
Just try 10 minutes.
You were able to let her in?
I believe so. Do you
Okay,
see it
great.
anywhere?
Oh yeah, I think it was Lauren, right?
Yes, it was Lauren.
Okay, great.
Thank you.
Okay. And then back where we left off with stage C. So this is when our patients are now presenting with symptoms of heart failure. And then stage D is that advanced heart failure. And then we have the New York Heart Association classifications of heart failure. So classes 1 through 4. Again, this is just shared for your reference. Not much has changed about this part of the guidelines. What has changed a little bit from previous, the 2013 heart failure guidelines are the AHA, ACC classifications of heart failure, or the titles that they designate each of these classes of heart failure. So to start us off, with patients that have an ejection fraction of less than or equal to 40%, we still consider those patients HFrEF, but now they get moved into they can be moved into a reclassification of heart failure with improved ejection fraction, which previously was just considered heart failure improved, but now they have classified this as a new abbreviation and things like that that were included in the guidelines. And again, these are our patients that have ejection fraction greater than 40%. The next is heart failure with moderately reduced ejection fraction. So these are the patients that fall within that gray area of ejection fraction between 41 to 49%. These patients were previously considered to be borderline heart failure patients. So now there is a more direct classification that they would fall under. And then reclassification for those patients is listed on over to the side.
What does MR stand for, do you know?
Yes,
Mildly reduced?
it's
Yeah.
mildly reduced.
Okay.
Mm-hmm.
They sometimes use slang of mid-range as well, I believe.
Okay.
But
Yeah.
Gotcha.
And then lastly, our HFpEF patients, and that hasn't changed either. And then of course, those patients can always be reclassified into one of the other groups. Again, this was included for your reference to kind of give you a guide of how the guidelines rank their recommendations. So green being the strongest, and then moving through the colors. Well, I guess that's also a strong recommendation of red, but they kind of rank from the best recommendation to the most harmful recommendation, and have it color coordinated for you to better understand. I will use several graphics from the guidelines throughout the presentation that use these colors, so I just wanted to make sure that we all knew what they signified. So starting off, treating our patients at risk for heart failure. So our stage A patients, so these are patients that have those comorbidities that put them at risk of developing heart failure despite the fact that they have not presented with any symptoms and don't have any prior structural heart disease. The main update to this guideline is a focus on SGLT2 inhibitors, which will be a main focus of the presentation today. So it's important to note that now this is a recommendation that is specifically provided by the guidelines themselves. Moving on to our pre-heart failure stage B patients, this is where we start to move into more of our traditional guideline-directed medical therapy using our ACEs and ARBs and beta blockers. And again, these are for stage B patients that do not have symptoms, but may have other qualifying factors that lead to heart failure in the future. So the recommendation for adding SGLT2 specifically to the guideline recommendations is supported by the findings of the EMPA-REG trial. So this was a trial that included roughly 7,000 patients with a mean age of 63 years. They were all patients that had type 2 diabetes and had a high risk of a cardiovascular event. Each of these patients were assigned to receive the doses listed on the screen of empagliflozin, or the brand name is Jardiance. You may recognize it as that. And the primary outcome was composite death from cardiovascular causes, non-fatal MI, or non-fatal stroke. So looking at the table to summarize the results of this study, each of these outcomes that were listed, so composite outcome and each of the individual outcomes that contributed to that composite, did show a statistically significant reduction in patients that received empagliflozin versus those that received placebo, including death from any cause and cardiovascular death, and then heart failure hospitalization. Next was the DECLARE-TIMI trial. This was a very similarly structured trial, but now focusing on the use of dapagliflozin instead of empagliflozin. This included a larger number of patients and a similar mean age of 64 years, and again, a similar patient population of those with type 2 diabetes at risk of a cardiovascular disease. The primary outcomes in this study were major adverse cardiovascular events, composite of CV death, or heart failure hospitalization. As we can see here, the composite outcome of CV death and hospitalization did have a statistically significant difference in the patients that received epagliflozin versus those that received placebo, and this was largely contributed to the significant reduction of heart failure hospitalizations. So just another study that's proving the benefit of these SGLT2 inhibitors in patients with heart failure. Moving on to treating patients that have a true diagnosis or a more advanced stage of heart failure, specifically focusing on HFrEF or reduced ejection fraction at this point. The guidelines do recommend in our patients with ejection fractions less than 40%. Now the recommendation for first-line therapy is initiating an ARNI or an angiotensin receptor neprilysin inhibitor over initiating patients on an ACE or an ARB. Patients that have already been treated with an ACE or an ARB, it's recommended as long as patients were previously diagnosed with heart failure, that's what they were stable on. It's now recommended to transition them to an ARNI, and we'll go over the literature that supports that as well. And then our more traditional GDMTs with beta blockers, MRAs, or mineralocorticoid receptor antagonists. And then SGLT2s have also been added to the recommendations for these patients as well. And we'll go over the data that supports those recommendations. So going over the role of the ARNIs in heart failure, first I wanted to discuss the mechanism of action of these medications. So a ARNI is a mixed or a combination product of valsartan, which is an angiotensin receptor blocker, and then sacubitril, which is our neprilysin inhibitor. And what neprilysin, or the neprilysin inhibitor does is it blocks the enzyme neprilysin from metabolizing our body's natriuretic peptides that go on to have beneficial effects in our patients with heart failure, causing vasodilation and putting a decrease on the improving cardiac output by increasing the amount of BNP that's floating around in the patient's body. So the first trial that I'd like to review is the PARADIGM trial that had roughly 8,000 patients with a mean age of 64 years. They had chronic heart failure characterized as HFrEF and all had elevated BNP. The primary outcome was to demonstrate that use of sacubitril valsartan or Entresto was superior to enalapril or an ACE inhibitor in reducing the composite of death from cardiovascular causes or first hospitalization for heart failure. As you can see on the slide or on the table to the right, each of these outcomes was proven to be statistically significant in reducing patient death, patients' hospitalizations due to heart failure, with a number needed to treat as low as 21. The next study that supports the use of Entresto in these patients is the PIONEER trial. This was a smaller study that had roughly 900 patients with a median age of 61 to 63 years. These are patients that were already hospitalized for acute decompensated heart failure. They had ejection fractions less than 40% within the last 6 months and then had elevated NT-proBNP and BNPs and were considered to be stabilized at the time of randomization. The primary outcome was the time averaged proportional change in NT-proBNP from baseline, and then they reevaluated it at 4 and 8 weeks. And again, we can see in this trial that each of its findings were found to be statistically significant with reductions in patients, greater reductions in patients that received Entresto versus those that received an ACE inhibitor. So like I mentioned previously, ARNIs are now considered to be the first-line therapy in HFrEF patients. They have been proven to prevent cardiac remodeling. They provide greater reduction in mortality and hospitalizations in patients that have HFrEF, more so than those ACEs and ARBs that we previously relied so heavily on. And the current recommendations are patients that were previously prescribed ACEs and ARBs for heart failure or HFrEF should be switched over to an ARNI to have beneficial patient outcomes in the future. As for monitoring for these medications, it's similar to ACEs and ARBs. Whenever it comes to checking pertinent labs in a patient that with heart failure to assess for exacerbations and what have you, it's recommended to assess for NT-proBNP over assessing for BNP, as the mechanism of action of this drug is to increase BNP, but it will not have effects on that NT-proBNP. And it is potentially a blood pressure lowering medication that can cause hypotension, so that's something to keep in mind as well. Something that's important to remember whenever you are transitioning patients that were on an ACE inhibitor prior to switching to Entresto is that there is a 36-hour washout period from their last ACE inhibitor dose. So it's important to make sure that patients have that education piece when you prescribe them this new medication. And then angioedema is a contraindication for this medication, just like it is for the others, especially or even in patients that have history of angioedema. And then the target dosing is available for your reference on the side. So we typically start at the lower end at the 24 per 26 milligrams twice daily, and then work our way up to the target dose of 97 per 103 twice daily. It is important to note as well that this is a twice daily dose medication. I know that I've run across patients in clinic that had forgotten that piece, so that's the important education piece as well. Moving on to the role of SGLT2 inhibitors in heart failure. This is where we'll really get into a lot of studies and discuss the benefit that these medications present for our patients. But first, we'll discuss the role of SGLT2 inhibitors. So as you can see here in the proximal tubule, that SGLT2 is a sodium glucose co-transporter. It is the main area of glucose reabsorption in the proximal tubule. And it also, as a co-transporter, works on sodium reabsorption as well. So in our patients that have high blood glucose, and in theory, we want our SGLT2 inhibitors to work in this area to block that sodium glucose transport, so our body is reabsorbing less and less glucose, lowering overall blood sugars within the bloodstream. This leads to further glucose being excreted in the urine, increased diuresis, as we're also causing our body to hold less and less sodium, and having a blood pressure lowering effect as well. The first of many studies that we'll review that have shown a benefit with SGLT2s in heart failure is the DAPA-HF trial. This looked at roughly 4,700 patients with a mean age of 66 years. These patients had NYHA class 2 through 4 heart failure with ejection fractions less than 40%, and they were randomized to receive either dapagliflozin or placebo. The primary outcomes for this trial was the composite of worsening heart failure, which was classified as hospitalization or an urgent visit resulting in IV therapy for heart failure, or cardiovascular death. As you can see in the table, each of these findings was found to be significantly or statistically significant, showing the benefit of dapagliflozin in these patients, leading to lower occurrences of death, cardiovascular death, heart failure hospitalizations. And all of these findings were consistent among patients, regardless of the presence or absence of type 2 diabetes. So this is where we got the first hint that potentially SGLT2s have a benefit in patients outside of their first indication of diabetes. This next trial is very similar, the Emperor Reduced trial. It included a very similar patient population The only difference is patients received empagliflozin or Jardiance in this group instead of the dapagliflozin in the last trial. And as you can see, again, this showed a statistically significant reduction in heart failure hospitalizations in patients that had empagliflozin over those patients that received placebo. And these findings were, again, significant significant regardless of the presence or absence of type 2 diabetes, showing that this could have a benefit in heart failure patients with or without that comorbidity. So like I mentioned, SGLT2s were not originally created to be heart failure medications. They were first created to be medications to treat type 2 diabetes. So they do have a reduction of A1C. Per the diabetes guidelines, they are the second oral agent recommended to be added after metformin. And they're one of the preferred agents by those guidelines for patients that have ASCVD risk factors. Other known benefits of these medications are a reduction in blood glucose and A1C. So if you do by chance have a patient that is struggling with meeting those goals, this would be just an added reason to consider one of these medications. In the long run, they do prevent AKI, they provide renal protection, and they aid in weight loss and blood pressure reduction. For your reference, I have the dosing recommendations of each of the SGLT2s that are available on the market. The top two, dapagliflozin and empagliflozin, are the only two that are indicated in heart failure patients. The other two have not been able to provide data or have not been studied yet in this group of patients, but the dapagliflozin and empagliflozin, both, as you've just seen, have trials that have shown that they're beneficial in this patient population. The dosing is different for heart failure versus type 2 diabetes, so it does make it a little bit easier to remember that they both, for heart failure, are dosed at 10 milligrams, so that's nice. And for diabetes, doses can go a little bit higher, so if you do see a patient that's on a different dose, you want to make sure that they are on the most appropriate dose for both indications. These medications are also renally dose adjusted, so you want to make sure, again, that we're monitoring patients' renal function prior to initiation of these medications. These are some of the more common adverse effects that it's important to make sure that patients are educated on. So the first being genitourinary infections. This is by far the most common side effect that's seen with SGLT2s, because the fact that we're causing our body to excrete more glucose, that becomes potentially a feeding ground for bacteria. So it's very important that patients are educated on the need for appropriate hygiene, or just assessing for patients that may or may not be able to have that hygiene upkeep, specifically considering patients that maybe are in nursing homes with catheters or things like that. Hypotension is another potential side effect, since we are having this volume depletion taking place by causing that increased diuresis. However, this was mostly seen in patients that were elderly or previously renally impaired or had other medications on, like other diuretics, that caused an increase in volume depletion. It can also lead to a very self-limiting AKI. So at the beginning, upon initiation, as patients are kind of adjusting to this new medication and the increased diuretic effect of the medication, they are at an increased risk of AKI, but overall studies have shown that SGLT2s in the long run have a renally protective effect, so this isn't something that we would be worried about in the long term. And then the fourth most common adverse effect is hypoglycemia, which is more likely in patients that have other blood sugar lowering medications on board, like insulin or our other insulin secretagogues. I have them listed here on the slide for you. These are medications that work to lower patients' blood sugars despite what their actual blood sugar is. The more rare side effects that patients are at risk of, but could potentially be harmful, I have listed on the slide for your knowledge. So Fournier's gangrene, especially if a genitourinary infection goes untreated. So again, this falls into that piece of making sure that patients are selected carefully and educated appropriately for proper hygiene. Euglycemic ketoacidosis is another rare side effect, but it is indicated as a safety alert by the FDA. So patients that are at the highest risk of having this DKA from being on an SGLT2 are patients that had a recent significant reduction in their previous insulin dosing, patients that are facing a calorie restriction, patients undergoing surgery, and potentially patients with an infection. The recommendations for patients that are on SGLT2s that are planning to have a procedure or surgery is to discontinue the therapy for 3 days prior. There's also a warning for bone fractures in these patients. There's really very little evidence that has shown the occurrence of this side effect. It showed to have an increased incidence in just one single trial, which led to it being added to the package insert as an adverse reaction. And I have that trial listed here for your reference as well. And then I think amputation can seem very intimidating, especially whenever we're wanting to start this medication in some of our higher risk patients. However, there is very conflicting data, and there's very little data involving empagliflozin and dapagliflozin causing amputation. The one SGLT2 that has the highest risk of leading to amputation is canagliflozin, and that's not one that we use in our heart failure patients. And then, of course, with all medications, severe hypersensitivity or allergic reaction can occur. Moving on to our more tried and true heart failure medications. I won't go into too much detail, but I wanted to make sure that we had the information as it was included in the guidelines. So ACEs and ARBs are still considered first-line therapy in our patients that have stage B heart failure, even in patients with HFpEF, or I want to call it HFmrEF, but heart failure with mildly reduced ejection fraction.
I think we should start that.
I know.
HFmrEF.
It's more of a consideration on which you would like to start ACEs and ARBs versus an ARNI. And then ACEs and ARBs have now moved to an alternative first-line therapy in HFrEF patients. And then starting doses and target doses for each of these medications is provided for you in the table as well. With our beta blockers, these have been first-line therapy for heart failure for a very long time, so I don't think that we need to review these very heavily, other than our target doses for beta blockers, because I feel like this is an area that we don't commonly or we're not able to always achieve in our patients, so it's a good reminder of what our target doses are as long as our patients can tolerate them. The one that is the most unique is carvedilol. So this is our twice daily beta blocker for heart failure, and it is a weight-based recommendation on what the target dose is. And so for patients that weigh less than or equal to 85 kilograms, our target dose is 25 milligrams BID, versus patients weighing more than 85 kilograms, our target dose is then increased to 50 BID. So that makes it a little bit unique compared to the others, which is more just based off of patient tolerability. For our mineralocorticoid receptor antagonists, again, these have been part of our guideline recommendations for a while now, so I won't go into too many details here, but wanted to make sure that we just address the starting dose and target dose for each of these medications, and the fact that they are renally dose adjusted, and that may impact the dose that you choose or aim for in the future. And then, of course, our other therapies like adding on diuretics to help patients that are symptomatic with evidence of fluid retention. So we've got multiple options here that are available to us. And I know you guys are very familiar with these, so I won't go much further about these medications. And then we also have other add-on therapies like isosorbide dinitrate and hydralazine combination therapy, which have been proven to provide symptom relief and reduction in morbidity and mortality, specifically in African American patients. So those are potentially beneficial add-on medications that we can provide to patients that fit that description. We do have other add-on therapies at our disposal. So ivabradine has been around for a bit, but we do have two new ones, two newer ones that I'd like to mostly focus on. So the first one is this vericiguat, which is a guanylate cyclase inhibitor. It basically works to help cause vasodilation and smooth muscle relaxation to help reduce some of those impacts on blood pressure that are associated with heart failure exacerbations. We also have the addition of potassium binders in patients that become hyperkalemic while taking medications that work by targeting the renin-angiotensin system. So our potassium binders that we have available basically work by trying to bind to the extra potassium that is floating around in the body, so that way it's not leading to adverse events for our patients. This is just a summary slide in case the graphics maybe don't make sense, or if you prefer to just see it as a list instead of going through them all one by one. And then I have bolded the two newer recommendations by the guidelines of recommending ARNIs first and HFrEF in addition of SGLT2 inhibitors. And if presenting all of that data wasn't enough to convince you, the guidelines also included this nice chart that summarizes the number needed to treat to show an all-cause mortality and heart failure with reduced ejection fraction with each of these medications. So we can see here specifically that ARNIs and SGLT2s have a pretty comparable number needed to treat as some of our other heart failure, or staples of heart failure medications like our ACEs and ARBs. So I thought this was really impressive to see how beneficial that these medications actually are, and comparing them to some of our other therapies that we've been using for quite some time now. Before we move on to the other classifications of heart failure, I've included a patient case for you all to review to give us some practice. So we have a 64-year-old male who presents with shortness of breath for the past 4 months that's progressed to an extent that he's been unable to perform his daily activities, requiring 3 pillows to sleep at night and complaining of orthopnea. His past medical history includes hypertension, dyslipidemia, type 2 diabetes, and a triple bypass surgery 4 years ago. And then his other pertinent history and labs and vitals are listed there for you to review. So I'll give you a moment to look at all of those. And then if anybody would like to either unmute themselves or maybe share in the chat the answer of what changes they would make to the patient's therapy based off of what we've learned from the guideline recommendations.
Anybody? Well, I would say probably switching the lisinopril to Entresto and maybe considering adding an SGLT2.
Yeah, so that's pretty much exactly what we thought as well. So changing that lisinopril to Entresto, remembering the fact that there is that 36-hour washout period, recommending to add an SGLT2 in this patient and then potentially adding a diuretic as well. And then making sure to titrate and optimize therapy every 1 to 2 weeks as recommended by the guidelines too. So for our patients that fall into the classification of heart failure with improved ejection fraction, so these are our patients that previously were classified as HFrEF that have now had a rise in their ejection fraction to above 40. And the recommendations for these patients listed by the guidelines is to continue the previous therapies that they were on, titrating and maybe adjusting doses to patient tolerability, as though we don't want to potentially cause a relapse, as you could say, or a potential heart failure exacerbation, putting them back into that HFrEF category. So we've got our follow-up with that same patient who presented to us 6 months ago, now requesting an appointment due to complaints of continued swelling in his lower legs. He still reports having occasional shortness of breath, but it has improved since his last visit. We've made our changes to his medication therapy. Go ahead and take a second to review and then let us know what changes you think could be made to his therapy based off of his presentation today.
I always tell everybody to wear compression socks.
Yes, it's not, yeah. So not always adding on medications, but sometimes just some non-pharm stuff can help.
Then probably, I mean, he could probably increase his furosemide a little bit. He's not on a very big dose.
Yeah.
Depending on what his heart rate is, maybe increasing the metoprolol.
Yeah, those are all good recommendations. And that falls pretty much in line with some of the things that we said as well. So his ARNI was already at his target dose, same for his spironolactone, though we also agreed to recommend titrating the beta blocker and then maybe recommending to adjust the diuretic dose as well. And like Meredith pointed out, maybe wearing some compression socks would be helpful. Moving on to our patients that have heart failure with mildly reduced ejection fraction. So these are our patients that are in that gray area. Are they HFrEF? Are they HFpEF? Now we have something to classify them as and specific recommendations for how to treat these patients. So first and foremost, treating them with diuretics as needed to relieve symptoms. There is a secondary recommendation to consider adding on SGLT2s in these patients, as this could potentially progress to becoming HFrEF. Maybe an SGLT2 would provide similar benefit in this group. And then again, our recommendations for our other GDMT, like our ACEs, ARBs, and ARNIs. Like I said before, this is kind of that area of you can kind of weigh your options on whether you want to go straight to an ARNI or if you want to start with an ACE or an ARB. Since they fall within that gray area, it's kind of up to your own clinical judgment which you would prefer. And our trial that gave the recommendation, or that secondary recommendation, to consider SGLT2s in this patient population is the Emperor Preserved trial. So this looked at patients that had an EF of greater than 40%. And these patients did receive empagliflozin or placebo in addition to their GDMT therapy. So here we were looking to see if there was the same added benefit in patients that fell into that gray area and or HFpEF with SGLT2s, as was seen in patients that had HFrEF.
And this is regardless of whether they have diabetes, or was this diabetic patients?
So this included patients with and without diabetes. They didn't make the specific classification in the trial that it was, that they did in previous trials where they said it was seen regardless of presence or absence, but they did mention that there was a trend towards showing similar results in patients with or without, but it wasn't as strong of a Like,
Strongly stated.
yeah, it wasn't as strongly stated
But it
as
does.
it
But
was
it was
before.
studied in patients with and
With
It was,
okay.
yeah, this patient population did include both, yeah, patients with
Gotcha.
and without diabetes. And again, we showed a reduction in heart failure hospitalizations in these patients. So our next patient we have is a 71-year-old male that presents with dyspnea on exertion that's worsened over the last several months. He's been sleeping in his recliner and having ankle edema. His primary care provider referred him to clinic for additional evaluation and management. Currently independent in his ADLs while he can comfortably shop at his local supermarket. Sometimes he has difficulty while carrying his stuff home, and he wants to return to his previously active lifestyle. I'll give you a second to review the other information, and then we can discuss.
So he's just taking the furosemide PRN.
Mm-hmm.
Does anybody have any suggestions? I don't want to hog all of the
It's okay.
answering. I would probably switch his losartan to Entresto, have him take a higher dose of furosemide every day, and then maybe consider adding a SGLT2. I would personally, I don't like to make too many changes at once, so I'd probably do that first and then add on the SGLT2 a little later on.
Sure, I think that's reasonable. So as the guidelines recommend, so diuretics, yes, so making a change to his diuretic therapy, potentially adding on an SGLT2 and or switching from an ACE, from the, I think he was on losartan, so the ARB to the ARNI, those would all be potential changes that you could that you could make that would be supported by the guidelines. Now reviewing recommendations for patients that have HFpEF. So these recommendations really haven't changed a whole lot other than that conditional or consideration of adding SGLT2s in patients that fit into this diagnosis of heart failure with preserved ejection fraction. So our next patient is a 58-year-old female presenting with shortness of breath that's increased over the last few months. Her echo results are listed on the screen for you as well, and then we can discuss what changes you may want to make to her therapy.
I would probably increase her metoprolol depending on what her heart rate is and blood pressure. And maybe start her on some Lasix or furosemide and an SGLT2 inhibitor.
Okay, I think those are reasonable recommendations.
And then maybe an ARNI.
Yeah, so our guidelines do support using diuretics in these patients. So she was already on hydrochlorothiazide, but adding on a loop diuretic could potentially provide some benefit for her as well. Considering to add on an SGLT2 and or switching to an ARNI, and then making sure that our other GDMTs are at target dose or maximally tolerated doses is appropriate as well. And remember that data that was presented from the Emperor Preserved trial showing a significant reduction in heart failure hospitalizations is what has led to this recommendations of considering SGLT2s in HFpEF patients. And then there's a segment in the guidelines that provides additional recommendations that are comorbidity specific. Most of them do include trying to optimize patients' therapy based off of disease-specific guidelines. They do put in another plug for SGLT2s here in the diabetes section, even though we have data that supports its use with and without. Let's see. Really for this section, I think for the most part, this is just a reminder to be looking at our patients as a whole and seeing if there's anything else that we can help to optimize that could maybe be causing and or exacerbating heart failure symptoms. Is there anything else you wanted to add to this slide?
Not exactly. I do think that the IV iron replacement is not necessarily a new recommendation, but it may be something that may be overlooked often from the 2017 update. So I don't think it's unreasonable if all else fails and patients are still symptomatic to potentially pursue that route and looking into seeing if you can get them some IV iron supplementation.
Thank you. The next update to the guidelines does largely revolve around cardiac amyloidosis. This is a very niche group of patients that we are very lucky to now have a therapy or medication that we can treat them with. This next slide is more so for your information. This is taken from the guidelines as some signs of things to either watch for in patients that are presenting with that could possibly be cardiac amyloidosis, and then some of the diagnostic tests that can be ordered to help rule in or rule out this disease state. So the main focus of the recommendations from the guidelines now are a new medication called tafamidis. It is a medication specifically for cardiac amyloidosis that works to reduce cardiovascular morbidity and mortality. It works by binding to the transthyretin tetramer to stabilize that tetramer and basically, I guess, slow down or inhibit the amyloidosis from occurring. It is available in 2 different formulations. They go by 2 different brand names, which are now escaping me. But the specific dosing recommendations are available here on the slide for each of those formulations. Just to point out that they are not one-to-one conversions. So the tafamidis meglumine is 20 milligram capsules, and it's dosed 80 milligrams once daily, while the other is just a 61 milligram capsule. There is no monitoring or adverse events that have been reported by the manufacturer. I'm assuming this is because this is still a very new to us medication, so there will hopefully be more information on that to come out. And another piece of advice or something to keep in mind about this medication is this is not one that we would have on formulary, and it's not one that is commonly accessible at your average community pharmacy. It's only available from specialty pharmacies through the drug manufacturer. And then patients that have cardiac amyloidosis and present with heart failure, we want to try to individualize these patients' therapy. It is possible that their symptoms might be worsened despite being on GDMT therapy because of this comorbidity of cardiac amyloidosis. And then they also made the recommendations for patients that also have atrial fibrillation to initiate anticoagulation regardless of their CHA2DS2-VASc score if they also have the diagnosis of cardiac amyloidosis. The next area that is highlighted by the guidelines is medications to avoid in patients with heart failure, as they may cause harm or have no benefit in these patients. So I have them listed here for you by drug class. So our dihydropyridine calcium channel blockers, are not recommended in these patients. They've been shown to have no benefit, and I have those listed here for your reference. But the ones that are have shown to be harmful are on the bottom half of this chart. So we have our non-dihydropyridine calcium channel blockers, or verapamil and diltiazem. Some of our antiarrhythmic therapies like flecainide, sotalol, and disopyramide. And then our thiazolidine diones, which are diabetes medications, so pioglitazone and rosiglitazone have shown to be harmful. And then the dipeptidyl peptidase 4 or DPP4 inhibitors, which are another diabetes medication, have also shown to increase the risk of heart failure hospitalization or heart failure exacerbations. And then for most of our cardiac patients, this is no change, but NSAIDs can potentially worsen their condition as well. So those are all medications that to be on the lookout, especially in patients that present maybe with worsening symptoms, looking at their medication list to help identify if there's something that could be causing it. Our last patient case of the day is a new patient that's presenting to your office to establish care. I've got their list of medications that they take and what their current past medical history and whatnot is. For this case, just making a recommendation or trying to identify the potentially harmful medications that this patient is currently taking.
Definitely verapamil.
Pioglitazone, yes.
Oh
Oh,
yeah.
is that what they said?
Yep.
Yeah, pioglitazone. So we've got pioglitazone, verapamil.
Oh, the naproxen.
Yeah, so verapamil, pioglitazone, naproxen, and there's actually one more that got hidden as a combination medication.
Sneaky, sneaky.
So verapamil, saxagliptin, pioglitazone, and naproxen.
So saxagliptin is that one of the DPP4?
Yes.
Oh, okay.
Mm-hmm.
I am not as familiar with those.
Yeah. And it's okay if maybe you don't feel comfortable or don't recognize some of these medications, especially as they're more commonly referred to by their brand names. You can always phone a friend, aka Tiffany or I, or your pharmacist, to see if maybe we can help identify potentially harmful medications too. For my references, I'd be glad to answer any questions that you all may have.
I have a question. So after starting the SGLT2 inhibitors, do you know when or if we should be checking renal function after we initiate it?
So I know renal function is something that we monitor with SGLT2s. The specific timeline, I'm not 100% sure of.
So what I've traditionally read is the monitoring is similar to the RAS inhibitors, so ACE, ARB,
Okay.
ARNI. So you were going to anticipate a little bit of a bump in serum
Sure.
creatinine. And so if it's like that initially, if it's, me personally, that I don't know if this is in the guidelines, but we always use that 0.3 as a measure. So if the serum creatinine increased by more than 0.3, then potentially holding it at that moment. So I would do traditional monitoring like you would do starting an ACE and doing it in 1 to 2 weeks.
Okay.
And then kind of symptomatically after that, or with any, you wouldn't be increasing the dose, so you wouldn't need to do continual
But if
assessments
there's
after that.
mild elevation, maybe recheck it again in 2 weeks. Because
Yeah.
I mean, how long does it take? Because you said that there was some acute renal insufficiency that may occur with initiation. So how long after initiation does it tend to kind of stabilize? Do you know?
That's a good question. I bet there is an answer for it. I can't speak to it off the top of my head. I'll see if LexiComp has anything specific in here.
Okay.
Meredith.
Yeah.
This is Jennifer Black.
I
Go
would just
ahead.
wanted to add to what you're talking about. There was something on the ACC podcast, I think last week, as well as another presentation that I listened to not long ago about SGLT inhibitors. But on the podcast recently, there was a small study that looked at those people that had a little bit higher bump in their creatinine soon after starting, that actually down the road had even better renal performance than those who didn't when you initially started the SGLT2 inhibitor. So they were really discouraging against being too quick to have kind of a knee-jerk withdraw the SGLT2 inhibitor, because it appeared, because of maybe the reduction in fibrosis, that they actually did better in kidney function down the road, even if they initially got that rise. So something to keep in mind.
Oh, okay. Did they happen to say how long it would take for the creatinine to stabilize, or they were just saying give it some time and recheck?
I think you can expect that it will stay up to some degree, kind of like you would with an ACE and ARB. But one of the other talks that I had listened to that was at the ACC conference, they talked about the fact that just like by rechecking it, then you just kind of know that's sort of their baseline now. And so, I mean, I guess if you had a really high rise, you'd be concerned. But if it's just like you would with the ACE or ARB, like you were saying, maybe 0.3 or so, just sort of accept that that's where they're at with this drug added. And so then you can kind of use that as their new baseline.
Oh, okay. That makes sense.
I can try to find I listened to a podcast. I can't remember the name of the study, but I'll see if I can find it for you. But
Yeah,
I think
that would be great.
as the pharmacists are saying, similar to the others, just accept a little change and not be too quick to withdraw, because it looks like the long-term benefit is so much better. But
Awesome.
anyway.
And we didn't cover the renal studies of SGLT2, so there are several studies looking at renal performance, essentially, and I think that those may be, if we can kind of look at them and potentially see if we can come up with a conclusion on those, specifically surrounding renal function.
Great.
Thanks for your talk.
Any other questions?
So I have a question. It may have been covered, but I missed it. But on the pioglitazone, how is it harmful for those with heart failure? Is it actually on the heart failure, or is it with the kidneys?
It's retaining fluid. They're known to retain fluid, so patients therefore become more symptomatic and have downstream effects accordingly.
I have another question. So on here it says no benefit with amlodipine and nifedipine, but I have a lot of heart failure patients who also have hypertension, and I treat them with some, either amlodipine or nifedipine. I mean, it says no benefit for heart failure, but if it's benefiting their hypertension, then that kind of goes with the guidelines, right? Because you're supposed to treat the hypertension.
I think they mean from a mortality benefit.
Oh, okay.
Yeah, that's how I interpret
how
it.
I interpret it as well.
Okay. Awesome. Okay, anybody else? Nothing in the chat. All right, 1 minute early. Thank you guys so much for joining our talk, and thank you to Tiffany and Alina for presenting. I will get this on our YouTube page and share it with everybody. But if you have any questions, Tiffany and Alina are available anytime, and they're a great resource. So thank you all for joining.
Thank you.
If only I could more easily figure out how to use. Okay, stop recording.